Okay, can you hear me? Right, it's Friday afternoon, okay? Who's tired? Because I'm pretty tired. Hopefully we'll make this as quick as possible, okay? I was saying to Gareth that last year he had this session and we never gave it because we ran out of time. So I was almost wondering whether it was even bothering to prepare some slides. So rather than have a lecture, I thought I'll present a case and we can discuss that, yeah? But if you want to go to sleep before Marty's talk, weaning on the oscillator or high frequency, you decrease your pressure settings, you keep decreasing your pressure settings. You don't do that until the patient's through that acute phase of disease. Remember, disease gets worse, it plateaus, then it gets better, right? So when it's getting worse, don't wean. When it's getting plateauing, let the baby get better. The baby will be better than you at getting the baby better. You've just got to know when the baby's starting to get better. Then you start turning all the numbers down and letting the baby do more, take the sedation away, then take it off the ventilator. That's the end of my talk, right? And we could just let Marty talk for longer, we could go home early. But I have put some slides together, and I promise I didn't do this on the fly though. So what do we need to think about when we get into the point of thinking that the baby or the patient is getting better and we want to start removing it from respiratory support so we can get it to the magical non-invasive ventilation holy grail that we need to be on? So we need to think about the oxygenation the patient's in, and also what oxygenation we're expecting this baby to get to be extubated. I'm not going to make a direct comment on that because at least in Melbourne, the extubation FiO2 is geographic, not physiological. Okay? You need to think about the CO2 removal that the patient and the ventilator are providing. Because ideally, you can't be off a ventilator if the ventilator is mainly the contributor to your minute ventilation. So you need to have an idea about what CO2 is going to be appropriate to extubate on. Okay, and that will vary a bit. If you've got a 1-month-old ex-BPD baby, you're not going to be aiming to extubate that baby in a CO2 of 35 or 45 or something. You need to think about the work of breathing that the patient is contributing to the process and how effective that work of breathing is. Because extubating a baby with significant work of breathing is going to cause you trouble, because you will take away some of the work of breathing support the ventilator might be providing, in theory. And then you need to think about the things that will help the baby breathe. And I won't talk too much about the beneficial things like caffeine, and maybe in this case, depending on which way it goes, because I've never presented this case, we might talk about some of the inhibitory things that impose weaning off a ventilator, and that's predominantly various chemical poisons that if you're a perinatal neonatologist, like most of you, don't like using. If you're a paediatric hospital neonatologist, you spend most of your time trying to work out how to get babies off very, very large doses of them that have been put on overnight. And then, and I don't know if Marty's going to talk about this, I'm not going to talk about it because we have no oscillatory data, we need to think about the role of the diaphragm, the major contributing muscle to ventilation. And there's no doubt that if you've been on a ventilator for a while, your diaphragm becomes less efficient and may start wasting. And that will be an important contributor to extubating some or weaning some babies. And that's why you may need to wean some babies on conventional in a different way than you would another baby on conventional. And I think Jane Pillow talks a lot about diaphragmatic wasting. I've been a slow converter, but now I'm a converted, disciple of Jane on these things. And I think that the diaphragm does waste with time. She's shown evidence in lambs. And we do need to think about how efficient the diaphragm is when we wean a baby. So again, what are we trying to do? We're trying to do the same things we are when we're managing an acutely ill baby and we're putting them on a ventilator. We need to get them to settings where they can oxygenate independently with minimal support and they can ventilate independently with minimal support. And now on the oscillator, I've added this line in, we need to think about the role of automated functions and modalities in terms of weaning. And I think this is where, again, volume guarantee and high frequency oscillatory ventilation is going to be very useful. I think it's going to be very useful in acute disease and stabilising a CO2. I think it's going to be very useful in helping guide recruitment, and I think it's going to be very helpful in weaning your baby because you're going to allow the baby to start weaning its delta P, and babies are always better at that than us. So, Canada and Australia are similar on many things. We have kept the same head of state. Most of the country, or at least some of the country, disagrees with that head of state. We're both generally surrounded by big neighbours who are a bit more dominant than us, and we have a vast amount of space. So I'm in Melbourne, which is like way down here in Australia, and this baby is currently in Darwin, which is way up here. So Darwin is in the far north, it's 3,500 kilometres away. It's got a small NICU. It is a town of about 200,000 people. It has a couple of neonatologists and generally run by paediatricians, the NICU. And they bought, I didn't know this, but they bought some VM500s a few years ago, and they've started oscillating a few years ago, which probably explains why they started showing up at our oscillator workshops, but a few years ago too. So they're new to high frequency, slightly different from Canada. They don't have a retrieval team. So, and their nearest level, like their nearest big city tertiary neonatal unit is at least 3,000 kilometres away without a retrieval team. We all tender out to go retrieve them because no one wants to, because you have to fly up there and then come back. So they called me, I think mainly because we ran the workshop, to say they had a 6-week-old baby with this chest x-ray who was an X24-weeker, weighed a bit over a kilo, was currently on volume guarantee at 2.2 kilos and had this sort of blood gas. And you can see was at that point in time on a mean airway pressure, I've got to work out how to do this, there you go, on a mean airway pressure of 18, with a delta P of 18 be delivered on this volume guarantee and currently in 50% oxygen. They said that was the best FO2 they'd had the baby in for many, many days. And they felt they were losing, they had no idea what to do and they wanted some help. I'll put it to you now, we don't need to discuss whether to wean this baby to extubate, but we'll get to weaning it in a minute. So just to keep you awake, what would you do? Sorry? Push the tube in, yep, they did that. No difference.
Would you possibly wean the map?
Yeah, so I said, why don't we wean the map? And they said, okay, we'll wean the map. And they dropped it to 16 and called me back and said the baby was in 60% oxygen and they were very uncomfortable weaning the map and they put it to 18. And then I said, oh, so what else could you do? You might not be able to see the other numbers. The frequency is actually, when they called me, the frequency was at 8. Yeah, we've already pushed it down. No difference. Sorry? So they were at a frequency of 8 and they were actually in a slightly higher FO2. And yeah, why would you go up in the frequency?
Because CO2 is on the higher side, 61.5.
Yeah. But you're only giving a delta P of 18 at the moment. And you're not that, your pH is 7.25, so you don't have a huge problem with CO2 problems. What's the problem this baby has? Sorry? It's got an oxidation. Why? What's the pathophysiological process? Yeah, it's got nasty, diseased preterm lungs that are becoming chronic lung. They're effectively going to be chronic lung disease depending on your definition. And what is the physiological process happening in this lung? You've got less alveoli. Those alveoli are big, big dilated things, and we have gas trapping, don't we? Yeah? Okay. I'm not a big fan of counting ribs on the oscillator. I use it as part of the assessment, but the only one trial that's reported counting ribs and accuracy with lung volume showed a pretty poor correlation. But you've almost got that opinion that you've got the bulging spaces here. You can clearly see you've got a nasty diseased lung that's gas trapping. So what do we need to do? We need to get, ideally we want to get the pressure down, and we want to give the lung enough time to inflate and deflate. So, and Marty can chip in and tell me all the bad things I was doing here, and I can tell you there is someone who in Australia after all this happened who had no problems telling me all the bad things I did, and disagreed with some of the issues. I told them to try to get the mean down, and I told them we should try to get the frequency down. I was a bit uncomfortable going below 7 here, because I felt, but I know there's other people that said drop that frequency to 5. If the baby was in Melbourne, I would have just put the baby on a jet. We wouldn't be having this discussion anymore. What else do I need to ask them? Sorry? It was 1 to 2. I did ask them that. They actually asked about 1 to 3, and I was a bit opposed to going to 1 to 3 because I was also because for a start I was a bit surprised they were on volume guarantee with a machine they'd only just bought a little while ago, and this was like their 4th or 5th baby that oscillated. So because they were asking, and they were obviously struggling a bit trying to work out how to use the volume guarantee, and I just thought we don't have any good trials of 1 to 3. There's not much data, and I didn't want them to get out of control. They were in a scary place at that point, and I wasn't sure. What else should I be asking them? I'm not there.
Look, you said that they weren't, that it was a new machine and that they weren't well versed in managing the volume guarantee. Would you ask them to take it off?
Well, they've already been trying that, and CO2 was never really a big issue. They were never in high dose peaks. The problem was they couldn't oxygenate this baby effectively without these high settings and this nasty looking X-ray. So, and they said, if you try dropping the mean like you said, it makes the baby worse. We've gone down to vertical 7, it doesn't make much difference. We frequently put the mean back up, and it doesn't make the baby better, it's stuck. So when you see a baby on an oscillator, and people are telling you they try lots of different things with the mean airway pressure, it usually tells you it's not the mean airway pressure, it's the primary problem. Well, we talked about that too, and I felt that the jet was the best mode, but I also didn't want to hand this baby over to the transport team and get told off of. Yeah.
I mean, sometimes they get stuck on oscillators.
So they had been on conventional earlier, yeah.
But you know, if
Yeah.
you want on an oscillator, sometimes somebody goes, well, let's try conventional.
Yeah.
You can,
Yeah, they sometimes, yeah, that's true, yeah. So we could have tried that, we didn't, because I asked him something else eventually.
How is the patient even dynamically?
Yeah.
The heart isn't skinny, but I mean, if you've got an oxygenation problem and, you know, he's a bit, I don't know.
Exactly, so they didn't have a problem with blood pressure, but they didn't have central lining, and they didn't have an arterial lining. But the blood pressure peripheral was normal, the heart rate was normal, and they don't have access to a functional echo.
So the lactates your.
So yeah, the lactates were normal, so they didn't feel that they had a significant cardiovascular problem. They said he didn't drop heart rate and things when they took the mean up.
I was just going to say, it doesn't look like it's the case, but ask them if there's any leak in the tube once they put in initially. But
No, so 0 lead. I'm not there, so eventually, after talking about all that stuff, I thought I should ask them what the baby was doing. I channeled my inner body, right? And I said, what's the baby doing? And they said, the baby's really agitated. And it doesn't like changing the mean airway pressure setting, and it's fighting us quite a bit. And I sort of said, okay, well, we might need to do something there. So what could we do? So I did say, what's the baby on? And I don't. So the animation didn't work there. They were already on 30 mics of morphine as an infusion, and they said they'd given a bolus of infusion, it wasn't getting better, didn't change the sedation. So what could we do?
steroids
So we talked about that. So we made it very clear in the discussion from the start that the goal here, we needed to think of a plan that got the baby stable enough. And I said to them, what would be how stable does this baby need to be for you to give it steroids? Because there's no point giving it steroids if it could take us 2 weeks to wean this kid off the ventilator, right? And they said, this is what we would do to give steroids. And I said, are you opposed to giving steroids? And they said, no, we would like to get the kid well enough to give steroids because we want to extubate it. And I thought, right, your framework's there, right? We all want the kid off the ventilator. The best thing this baby will do would be on CPAP or something that isn't an endotracheal tube. So we said we need to do something about the sedation, yeah? So I then suggested something quite controversial because, and I should have asked them what sedative agents they had, and I forgot. I said, let's muscle relax the baby. And then you nearly always, when you say that over the phone to someone, there is a pause from the response, and they usually go, really? Right? And it is quite controversial, and I probably could have done something different here. I couldn't think of anything else we could try, but in the end we talked about it, and we said it's 10 o'clock in the morning, let's muscle relax the baby, see what happens. And then we'll take it, we won't put him on infusion, we'll just give a dose and we'll see what happens. So they agreed, and 30 minutes after muscle relaxants, they called me and said they were now in 30% oxygen with SATs of 95, and they were in the same mean airway pressure, and things looked really good. Now what do we do?
his ventilation wasn't that bad. His pH of CO2 or specific chronic lung is okay. You've proven with whatever you did that the oxygen isn't that much of a problem. So now maybe the time to say, you know what, the window's here for steroids. If we don't have any infection, let's nail this kid and get him off the ventilator.
Yeah, I don't think the kid's quite ready for steroids because we're at a mean of 18. What we're ready for, I think what we got was control. We took the agitation away, and my take on it was, we've got control, we've got a lung we know we're over-distending, let's see if we can get this mean airway pressure down and see what happens with the baby properly, well not sedated, the baby could have been inappropriately sedated, at least muscle relaxed, and see what we could do. And so now comes a question of how do we wean?
All you've taken away is the headache of us watching the kid being agitated.
Yeah.
Because if you just muscle relax him, isn't he still under that agitated?
Well, that's the other. I'm not going to talk about whether he's properly, because I think he probably wasn't, but this is part of the problem being without not being at the bedside as well. So, but they were quite happy that they got control, and I suggested to them they keep weaning the mean airway pressure, and then they were a bit reluctant to do it as quickly as I said to do it, because I was impatient, but they weaned it, and 2 hours later they'd gone to a mean of 16, and the baby was now in 32% still and saturating well, so we said to them, why don't you keep weaning? And it was now getting to the end of the day, and the person was on. The next morning they phoned and said, we've got to a mean of 12, mean of 11, and we're now in 23%, and things are looking fantastic. And the baby is looking good, what do we do? Now comes the question of, what do you do? Because you've got to have in your head, what are the criteria for getting a baby off a ventilator when they're on the oscillator? And how are you going to manage that?
Is he still muscle relaxed?
Yeah, that's the problem. And I could tell you it was becoming a problem up there because a different neonatologist walked in and said, you cannot muscle relax a baby, this is dangerous. The meta-analysis shows you will increase brain injury. And we need to unmuscle relax the baby. And they did do that, and the baby desaturated very quickly in 30 of morphine. And they remuscle relaxed the baby, and then we were in a bit of a bind because they actually, I'm trying to remember what my next slide is. So they actually had the baby for about 24 hours while they were deliberating what to do in essentially air at a mean airway pressure of 10 and not quite sure what to do. And in the end, we had a bit of a discussion because I said, I think you're at the sort of settings where you really want to have the baby off a ventilator. And really we should be giving the baby some steroid and getting going and seeing if we can extubate it. And they were like, yeah, we really want to do this. And then but whenever they said we take the pank off and the baby gets really agitated. And then we were discussing this, and there was one person who was saying, I think this is actually medico-legally indefensible, and I was like, well, this is not helping, and I was trying to be diplomatic, which I usually don't do if I'm talking to units in Melbourne, but I thought it should be nice to people in Darwin, and I didn't know what they had up in Darwin. And then they said, what would you do here? And we were talking, we got caught up in a discussion around morphine, and on high-dose morphine, and should we give clonidine, and all this sort of stuff. And then we sort of said, do you have midazolam? And they said, oh, yeah, we've got that. Said, really? So they gave the baby a bolus of midazolam, and it liked it, and they took the muscle relaxant off, and it was fantastic. And then 24 hours later, the baby was in the same position, and I was going, geez, I wish I'd known they had midazolam in the first place, because we might not have had to muscle relax the baby. And then they got ready to extubate the baby, and they gave the baby steroid, and this is all happening now by text, not by phone call, so they were texting and saying, we've now got down to a mean of 8, the baby is on a small amount of midazolam and looks comfortable and is breathing. What criteria, what do we do now? We've weaned this baby, we've managed to get the mean airway pressure down. The question now comes, how do we extubate it? What should we do? Obviously pull the trigger. Yeah?
So, I foresee that.
Yeah, so you would extubate straight to sleep. And what criteria would you use to extubate a baby off the oscillator already? It's 11.
Yeah, most settings. You said you, but not based on that, you said your mouth was down.
Yeah, so just a couple of days later, they gave some steroid and got the baby stable for a few days and then said we want to extubate. How should we do that? What do you think?
Like your dog's piece over your mouth, so long you said that by 2 down or something.
It was in between 1 and 25%.
I don't know why you couldn't put it that.
Yeah, I just asked if you have numbers you use to pick how to extubate.
So we were talking about the mouth of the week, something like that.
Yeah. Anyone disagree? Who would go to SI? Who would not extubate or put baby in conventional first when you're trying to wean off the oscillator? You listen. Does
I
everyone?
love that answer.
Sorry? Yeah.
I wouldn't put the baby straight to CPAP.
Why?
Well, number one, you've got, see, the thing is, the baby was agitated with ventilation. So you think you have that under control with the combination of morphine and midazolam. I don't know if the baby's also now, you kind of sedate them, but then you give a respiratory stimulation with caffeine.
Yeah.
So you have that all in combination. But when you actually take out the tube, do you know if they're going to breathe? So CPAP might not give you the pressures, it might not give you the stimulation that possibly a baby that's 6 weeks old will get really upset at, but I would probably go to more of a cycle type of where the baby is getting intermittent, non-invasive breaths. I don't think I would.
But it's still extubate.
Oh yeah, but I
Yeah.
don't think I would go straight to CPAP.
So it comes up a lot in Amy when we get the babies on the oscillator in particular. I mean, you know if the baby's breathing because you can watch the baby and see pre-extubation if the baby is contributing to its own work of breathing. And the baby that told me, they said the baby breathing adequately on the oscillator, it doesn't get you struggling. Sometimes you get into a bit of a bias, especially with bigger babies. Is any agitation you have when the baby's looking otherwise well on an oscillator, is that related to the fact that the baby's just got the breathing tube? And if you take that away, the whole agitation goes away before you know the baby's on no sedation, because the problem is they're on ventilator. Or is it the bias flow of the oscillator coming in that's causing the agitation? Definitely bigger children don't like being on oscillators because of the bias flow thing. So, and the imposed work of breathing. So that's a question you have to have. I'm not saying that I know the right answer. What I'm saying is there are generally two ways. You can either extubate a baby to conventional ventilation, or you can extubate straight off the oscillator. Generally, I extubate off the oscillator because I'm pro-HFOV, and it's just CPAP with the wiggle. So if you take the wiggle away, it's just CPAP, so you may as well just go to CPAP. But I don't think there's anything wrong if the way you do it is to go to conventional, but I'm not sure you always need to do it. But that's my personal opinion. There's no trial saying how you should extubate one or the other. And I'm just proposing different ways to do it, and I was more interested in what people would say. There is some data, because I'm conscious I don't have much time, there is some data on the settings for extubating directly off the oscillator. And how we may be able to do it. And this is basically a cohort report from the Dutch, and they set the criteria of less than 30% oxygen, a mean airway pressure of 6 to 8, a delta P of less than 16, and importantly, and I think this is the most important part of it, satisfactory work of breathing, clinically assessing the patient before you extubated them, and they had to have a pH on a gas of greater than 7.25. And this was published a few years ago now, and they reported 215 infants. They all had early open lung higher frequency because it's the Netherlands, and they were extubated at a median age of 62%, and they had a 90% success rate with using these criteria to extubate. And the mean airway pressure they reported at the time of extubation was generally less than 8. So this is not an unreasonable set of settings, and I suspect for most people who are extubating off the oscillator, this is probably the criteria they're using in their preterm babies. I think Marty's going to talk about tests you can use for extubation. Personally, there's no data on different tests to use for extubation. I do sometimes put the babies on, take the delta P off on the ward round and just leave them on. If they're at a mean of 6 or 8, a small baby, or a little bit higher for a term baby, I might put them on ET CPAP via the oscillator. I just think about what flow I'm putting into the lungs when I do that. But I do take the delta P off and I just watch and see if the baby breathes. My work, it's a bit like the Camlin paper with conventional, but I reckon if you can cope on ET CPAP with an oscillator bias flow for a few minutes without delta P, you're going to cope without an ET tube at all entirely as well. But there's no evidence that's entirely antidotal, and I'd be the only one in our unit to do it. So in our unit, we've translated these findings on the preterm baby. For the term baby B, similar FO2, we accept a slightly higher mean airway pressure of 6 to 10, and we accept a slightly higher delta P in the bigger babies. But again, they have to have satisfactory work of breathing, and you have to have got the prep work right. You need to have your sedation managed, you need to have your stimulant drugs, if appropriate, managed, and again, the same criteria of the greater than 7.5. When I was flying over, I did think about what were our criteria for extubating off the jet. And actually, we don't really have any, but I tried to put some together on this sort of model. And again, it's similar. You would be using a jet peak. The peak is going to be low as you think the baby will cope. Jet pips, which are quite low. And ideally, we try to have our babies on no side breaths or one side breath when we're extubating. And again, it's all about the patient's interaction with the support it's getting. Weaning's about slowly taking the pressure away and allowing the baby to get used to doing more work, to the point where the baby is doing more efficient work if it didn't need the breathing tube in altogether. And this is the baby as it was a few days after extubation, and that's its post-extubation chest x-ray, because it's obligatory when you present a neonatal case to present a cute baby somewhere at the end, isn't it? Yeah. Unless you're Peter Dargaville, where he presents one of these cases and series of cases from the last one, and this is the cool bit about working at the Children's Hospital in Melbourne. We're on permanent on-call for the primate resuscitation team, newborn resuscitation team for the zoo. So, and his most famous case is the one where he resuscitated a gorilla. So it's the one that got the most YouTube hits and stuff. So, are there any questions?
What brand is that cannula?
Which cannula?
The CPAP cannula.
I don't know. It's 3,500 Ks from when they sent it. So I wasn't really interested at that.